Okay, so hello again, everyone. As promised, we are beginning here at 2 p.m. My name is John Collins, and I work with the Parkinson Society. And we've been partnered with the Registered Nurses Association of Ontario for now, I guess this is our fifth webinar, if you include an early one in 2013. And we've enjoyed that partnership together. It's allowed us to reach a new audience, and I thank you today for being part of that audience. We've covered a broad gamut of Parkinson's in our sessions, and today we arrive at, in my esteem, in my opinion, one of the more important sessions. There are things about Parkinson's that are very well understood, and there are things about Parkinson's that are not, and many of the non-motor symptoms fall into the latter category. So I do want to thank you for joining us, and I hope that you'll find today's session useful, whether you're someone working in practice or you're here for other reasons. So I'm just going to do some very minor housekeeping here before we begin. Again, during the session, if you have any questions, you can include them in the chat box on the lower right-hand corner of your screen. Depending on the flow of the presentation, and if I have an opportunity, I will pause our speaker and allow her to address it then. Failing that, we'll make sure that they are logged and addressed at the end of the session. If you have further questions, these are email addresses for Heather and myself, and you should have each of those through the preliminary emails. I'm happy to follow up after the session. Otherwise, I think I'd like to leave it to Heather now to introduce today's session objectives and some best practice ideas as well.
Thanks, John. Can you hear me?
Loud and clear.
Oh, good. Okay. All right. So what we want to do today is to share best practices for resident-centered care for people with Parkinson's disease, to look at an overview of the non-motor symptoms of Parkinson's disease, and to talk about strategies on how we can manage these symptoms. And for me, this has been a very interesting session to help in the preparation with, because I guess I wasn't as aware of some of the non-motor symptoms. So if you could flip to the next slide on resident or client-centered care best practices. Those are that best practices around ensuring that as we provide care to residents, that it's based on respect, human dignity, acknowledging that clients are the experts in their own lives and seeing them as leaders in care, and trying to ensure that the client's goals help to coordinate the care of the healthcare team. And things like being responsive and giving care in a timely fashion. So some of this that applies to this and what Sandy's going to talk about in a few minutes, and what I'm sure you're seeing is issues like that people with Parkinson's can have, are issues like drooling and excessive sweating. Sometimes we look at a person who's drooling and think, oh, brother, like that's gross. And we need to understand that it's very difficult for a person with Parkinson's to control this, and we need to figure out how to care for them in a really respectful way that helps them to meet their needs with these, the two conditions. I know when we talked about this, it brought to mind a resident in one of the homes where he sits in the lobby and basically in a pair of shorts, even when it's like 30 below the way it is now here in Thunder Bay, and it sort of takes one aback when you first look at the person, but then to realize, wow, there's a physiological reason for this, and that we need to be really sensitive to this and help other people to understand it. The next one, if you could flip to the next slide, John, is around the whole prevention of falls and falls injuries. And Sandy's going to talk about the challenges of orthostatic hypotension and double vision. And that orthostatic hypotension is when their blood pressure suddenly drops. And so these two things can very much contribute to falls. And what we're looking, in the best practices is that we assess residents' fall risk when they're admitted. Look at reasons why they might fall, and that we do this after they fall. And lots of you do this. And with people with Parkinson's, we need to be especially, careful about if do they have this orthostatic hypotension, sorry, and that might put them more at risk. And we might want to look at things like hip protectors. Do they work? we might want to talk to our resident who has Parkinson's and about this thing and how can we help them prevent it. Again, the focus on keeping them active, using a restorative care approach, but helping them to balance off this risk. Then on the next slide, this whole thing around screening for delirium, dementia, and depression in older adults. When you look at these non-motor symptoms, some of the symptoms are dementia and cognitive impairment, hallucinations, depression and anxiety, delusions, impulse control disorders. All of these things can be sometimes exhibited by people with Parkinson's. So we need to use this approach, a best practice approach of screening clients for changes in their cognition, their function, their behavior, and keeping in mind that these can be normal side effects of living with Parkinson's. And then the next one that goes along with that, the sister guideline, I call it, is the caregiving strategies. Like, how do we approach our residents who have these kind of conditions, and looking at, being aware that, these could be side effects. Then the last couple things I want to talk about is we have the best practice resource toolkit, and that has the information around the specific best practices. I also wanted to draw your attention, I didn't put it in these slides, but the Parkinson Society has a wonderful tool on their website called the Non-Motor Symptoms of Parkinson's, and it's actually just an excellent overview of all the problems that people with Parkinson's can experience. And I highly recommend it. There's a companion guide for physicians that goes with it, and it's a really, really good resource for you to keep in mind when you're working with people with Parkinson's. And finally, I'll just mention the Canadian Guidelines on Parkinson's Disease. There's best practices that have been developed by the Parkinson Society of Canada, and they offer a specific advice around how to care for people with Parkinson's based on best practice and evidence. So over to you and Sandy there. Thanks, John.
Thank you, Heather. So I think that's helped characterize what we're going to speak about today and how it relates to RNAO best practices and just generally to care, specifically in a long-term care setting. What we'll actually be doing today is using this guide that Heather referenced that we do have available online, and we will send out after the session. It's been developed by a gentleman named Dr. Ron Postuma and does focus on a wide variety of non-motor symptoms of Parkinson's. It is designed for patients, so some of the graphics, some of the text, all designed to be very easy to understand, but we're going to speak to it from a care point of view, from a professional practice point of view. Sandy Jones is with us today. Sandy has been on staff with the Parkinson Society for 16 years. I used over 15 earlier, and I guess I pegged that pretty well. So 16 years she's been here. Prior to that, has a career as a nurse. So has the unique perspective of what it's like to work in care and also to work with clients with Parkinson's and a broad depth of understanding of the issues that they face. So I know that she's taught me a lot about understanding Parkinson's, and I suspect that she'll be able to impart a lot of wisdom on us today. So on that note, I turn it over to Sandy, and she's going to read the book. She'll tell you a story today, and again, if you have any questions, please feel free to ask them.
Thank you, John. Parkinson's disease has classically been considered a motor disease. And the cardinal motor features of the condition that we are all very familiar with are tremor, rigidity or stiffness, bradykinesia, which is a fancy way of saying slowness of movement, and problems with balance and gait, walking problems. These are the symptoms on which the diagnosis is based, regardless of where you go in the world. For the diagnosis of Parkinson's, these are the symptoms that over the years the doctors have been looking for. However, non-motor symptoms have, particularly within the last 5 to 6 years, become increasingly recognized, are often more disabling than the motor symptoms, and definitely have a very negative effect on the quality of lives of people with Parkinson's. It's important to understand that no two people with Parkinson's are alike, whether they have combinations of the motor symptoms and the non-motor symptoms. So please don't assume, as we speak about these symptoms today, that if you don't have this symptom that you're about to have it, etc. It's really a very, very unique. We call Parkinson's a designer disease because it's like a one-off. Everybody is different. The non-motor symptoms result from the degeneration of neurons, or the destruction of neurons, the cells that we have full of, our brains are full of, in widespread areas of the brainstem. And as a result, these symptoms do not necessarily respond to levodopa. Sinemet or Prolopa being the brand names of these drugs. And due to lack of recognition, these symptoms are often undertreated. Non-motor symptoms fall basically into three major categories: the autonomic system dysfunction. I call it the automatic system, because these are all of the things that happen to you and I on a daily basis, such as blinking, such as swallowing, all of those things that are no longer necessarily automatic for people with Parkinson's. So that's the autonomic dysfunction. They also, the other two categories, cognitive and psychiatric symptoms, as well as sleep disorders. So the goal of today's presentation is to help you.
Lakeland Long-Term Care
has joined the conference.
The goal of today's presentation is to help you recognize and manage these symptoms so that it will improve the quality of your lives as well as the quality of the lives of the patients that you are caring for on a regular basis.
And one thing I'd like to mention at this juncture, it's funny, I'm holding a post-it note for the entire session that I meant to address in my introduction and somehow managed to miss it. But you'll see here that we've arranged the slides around some areas of best practice in long-term care per the RNAO. So you'll see a few of the non-motor symptoms that we've lumped under client-centered care. Shortly you'll see one that we've related with falls and some of the other areas that Heather addressed in her introduction. So I will leave it to Sandy to discuss client-centered care.
Thanks, John. Okay, Heather has already mentioned I would consider two most prominent non-motor symptoms that I think fit beautifully into the client-centered care aspect of the presentation. The first two that I'm going to talk about are both very unpleasant for the patients as well as for yourselves to deal with. They are not well understood, and they may cause you to avoid spending time with your Parkinson's patients, which is really, I think, very, really too bad. So the first one we're going to talk about today is drooling. Drooling occurs in approximately 10% of people with Parkinson's. And the only other time in our lives when drooling occurs is when we're babies. And at that time it's considered to be normal and natural, and therefore it's well tolerated and accepted. But guess what? Not so much as adults. So if I could see you and you were in the room with me today, I would ask those of you who might know the answer to this question, how many times have you swallowed today? I'm hoping that nobody would put their hand up, because I would say to you, well, if you know how many times you've swallowed today, you need a life. There is a problem if you have time to count your swallows. However, as people with Parkinson's have this automatic or autonomic nervous system dysfunction, swallowing is no longer automatic for them. People with Parkinson's don't produce more saliva than you and I. The problem arises because of the automatic swallowing reflex. It's no longer automatic. And that, in combination with decreased mouth movements, result in a buildup of saliva which pools and then eventually leaks out of the mouth. So some cues or tips that you could use when you're dealing with residents with Parkinson's. One is encouraging them to chew on some chewing gum, believe it or not. There was a research study done fairly within the last couple of years by a movement disorder neurologist who thought that maybe cueing people with Parkinson's by having them chew gum before meals in particular might help them to continue that chewing process and swallowing process during their meals. Because we know when we put something in our mouths, I've got a bottle of water sitting beside me, and periodically today during the presentation, because my mouth will get dry, I'll take a little sip of water. As soon as we put something in our mouths, it cues our brains, aha, she's put something in her mouth, I need to help her to swallow it. And a whole bunch of mechanisms fall automatically into place. Well, again, that automatic swallowing reflex is broken with many people with Parkinson's, and as a result, that just doesn't happen so easily. So chewing gum can cue an individual. Also, if they don't have other swallowing issues, such as choking and coughing, etc., sometimes just having a hard candy close to them can trigger and increase their spontaneous swallowing movements. Ensure that clients always have a box of Kleenex handy and assist them with wiping their mouths whenever possible. John Paul, when he shared that he had Parkinson's disease many years ago, you would notice that there was at that time a cardinal who stood one on each side of him. And their job, primarily and really solely for him, was whatever side of the mouth his saliva was dripping from, because he with Parkinson's had this automatic problem as well, they would just go up and gently dab the side of his mouth. That was their job. So I'm not suggesting, because realizing that you don't have enough time to always spend with people with Parkinson's, but just ensuring them that they always have Kleenex and that you're there to help them if necessary. The medical treatments for individuals are sometimes medications like atropine, sometimes Botox injections can be used, but the side effects of these treatments and medications can often be worse than the symptoms themselves. So we're going to go on now to excessive sweating. Excessive sweating occurs in approximately 30 to 50% of patients. It's again a result of a malfunction of this autonomic and automatic nervous system. People with Parkinson's often have broken thermostats, so they are very susceptible to heat or cold, and sometimes even have what we call just plain spontaneous sweats. These things often occur during off periods when their medications are not working efficiently, or sometimes if they have the excessive movements known as dyskinesias. I call it the funky chicken, something like a movement that you would see with Michael J. Fox these days. When he's being interviewed, he never stops moving. Those excessive movements can also cause a great deal of sweating. The sweating usually occurs under the arms, in the genital areas that are under folds of skin, for example, sometimes just palms of hands and face and soles of feet. But as I said, sometimes people with Parkinson's experience drenching sweats. So the bottom line for those of you caring for people with Parkinson's, 1 bath a week doesn't cut it. You need to increase their ability to have either more baths or showers, or certainly at least provide them with a way or making sure that these areas of their bodies are clean. Whether you have to do that, whether you can assist them with doing that, whatever it needs to be, just make sure, because otherwise they're going to have body odor. It's not their fault. On to the topic of falls. So the following slides relate to possible causes of falls in people with Parkinson's. It's often said that it's not a matter of if a person with Parkinson's is going to fall, it's a matter of when. And how are they going to fall? Often poor balance and shuffling gait will contribute to these things as well. But some other contributing factors are, for example, orthostatic hypotension. That simply means it's a drop in a blood pressure when standing. The most common symptom that the person with Parkinson's will describe is lightheadedness and dizziness, particularly when going from a sitting to a standing position. It can also occur when they're going from a lying to a sitting position. Sometimes people complain that they feel more confused at these times. They can also have shoulder pain as well as an increase in their level of fatigue. Certain Parkinson's medications, for example, levodopa, the gold standard, the one most commonly given for Parkinson's, can make orthostatic hypotension worse. But orthostatic hypotension is part of the Parkinson's disease process in and of itself, as well as a side effect of medication. And because areas that normally increase blood pressure in the brain when people are standing also degenerate and deteriorate. So that's why orthostatic hypotension occurs in people with Parkinson's. You can encourage increased fluid intake, increased salt intake, depending, hopefully they don't have other layered medical problems, for example, problems with heart disease, etc. Avoid people having big meals. When people eat big meals, some of the blood pressure goes to the gastrointestinal system to assist with digestion, and so sometimes after a big meal, a blood pressure can drop and make people feel very tired as well. So smaller meals rather than large meals can help. The obvious things like elevating the head of the bed, using compression stockings, and certainly when you're dealing with people, either whether they're independent or you're assisting them with their activities of daily living, advise them to stand up very slowly and carefully. And when they're standing, before they move, they really should get what I call their sea legs, make sure that their blood pressure has indeed had an opportunity to balance itself again. Leg exercises can improve and bring pooled blood back into circulation as well. And try to make sure that you avoid dehydration, particularly in the very, very warm weather. Make sure people with Parkinson's always have a bottle of water with them. Double vision usually is caused by an underactive eye muscle. For example, just like the rest of the muscles in the body, sometimes eye muscles are also underactive. Eyes not moving in a coordinated fashion, in other words, they don't track. So for you and I to be able to see things clearly, our eyes need to be able to track together in a coordinated fashion. But sometimes for people with Parkinson's, again, because it involves messages not getting to muscles, eye muscles don't track together. Also, people with Parkinson's may have what we call visual spatial dysfunction. Big words. All that means is they really are not always aware where their bodies are in relation to their environment. So, for example, they may not see a chair close to them like you and I would. They may trip over things easily. Things like scatter rugs in homes are very, anything that they might trip over, those kinds of things have to be addressed. Increasing sometimes the Parkinson's medications can sometimes help, and then also because double vision can be caused by all kinds of things, it's important to rule out any other reasons why they may be having double vision. With respect to pain management, for many years, doctors, even the doctors that specialize in Parkinson's, said there is no pain associated with Parkinson's disease. Well, finally, patients with Parkinson's not only managed to convince them to do some research on this, but now the doctors absolutely agree that over 50% of people with Parkinson's do experience pain directly related to Parkinson's. It usually manifests as extreme stiffness, cramping, sometimes even spasms, and often occurs when medications are not working well. Sometimes when people are particularly dyskinetic, those are those wiggly wobbly movements I talked about a little while ago, or sometimes when they experience something called dystonia. Dystonia is like having a prolonged Charlie horse. So if any of you have ever experienced a Charlie horse, that usually occurs in the back of your calf, which is very painful. Some people with Parkinson's experience long Charlie horses, long periods of dystonia, which are extremely painful. Again, it's due to a degeneration of the dopamine-dependent centers in the brain that regulate our pain inhibition. Sometimes stretching, massages, warm baths can help, and often people with Parkinson's ask me, can I take any over-the-counter medications? The answer is yes. It is best to discuss that with your physician, but definitely you can do that, things like Tylenol, etc. But I always advise people to check with their doctors to make sure that what they're taking is not going to interact with any of their other medications. Also, an increase in Parkinson's medications can help with this. Sometimes some of the anti-neuropathic medications such as gabapentin have been given with success, and tricyclic antidepressants can be useful, especially if the pain is linked to depression. There is a direct correlation between the effectiveness of antidepressants and the brain's perception of pain. So sometimes this can be very helpful as well for people with Parkinson's. Leg swelling is actually a quite common side effect of the anti-Parkinson's medications, such as levodopa and some of the agonists that are given to people with Parkinson's. Definitely usually occurs in the lower leg and is not usually severe. So clients need to just, if they're having, for example, problems getting their feet into their shoes or their slippers, etc., they become quite alarmed because, of course, leg swelling is often linked to problems with cardiovascular issues. So, of course, those issues also need to be ruled out. But if all else has been ruled as not a possible cause, then leg swelling can be looked on as being quite normal for people with Parkinson's and definitely may not require treatment. Compression stockings can help, sitting with your legs raised, and decrease the Parkinson's medications, which is a very obvious one if the leg swelling is definitely severe and consistent and is of particular concern to both yourselves as well as to people with Parkinson's. The responsive behaviors of cognition on people with Parkinson's, quite alarmingly, the numbers that we have been made aware of more recently is that approximately 70%, some of the Parkinson's specialists say anywhere between even 70 and 90% of people with Parkinson's will experience either mild cognitive impairment or dementia. So mild cognitive impairment, which usually and very often does occur in early stages of Parkinson's, people may have problems with what we call the executive function. So they have poor planning abilities, poor ability, for example, to keep track of things, poor organizational skills, that sort of thing. Parkinson's disease dementia in later stages, and please note I did say later stages, people with Parkinson's do not develop dementia early on in the stages of Parkinson's. If an individual, for example, does develop dementia at the same time as their motor symptoms of Parkinson's, so if they have tremor, slowness of movement, stiffness, and problems with dementia during the first year of the diagnosis, that is not Parkinson's disease dementia, that is Lewy body dementia. That's a horse of a very different color. At any rate, Parkinson's disease dementia, so now we're back to talking about later stages, which is when you will see these folks, occurs quite often in patients over 65 years of age. It can involve slow thought processes, poor short-term memory problems. Many clients can't retrieve their memories. The analogy that I usually use is when they go to the memory bank sometimes, the memory teller isn't available. But if they go back after a few minutes, or even after, from a morning to an afternoon, the memory teller is there and they're able to retrieve the memory and take it out of the memory bank. The difference between Parkinson's disease dementia, for example, and Alzheimer's dementia or other types of dementia is that many people with Parkinson's do respond to cueing. So if you give them a cue that allows them to be able to retrieve that memory, rather than just saying, who does this look like? Or you could say, showing them a picture of their grandchildren, maybe just using one of the grandchildren's names. The short-term memory will definitely come back to them. So poor attention and concentration, poor perception abilities, as I said, it's often misunderstood with people with Parkinson's, again, because some of these cognitive issues means that, for example, they can just have slow thought processes. It takes some time to retrieve those, the memories, or to be able to formulate and process the question that you have asked them, but they can eventually come up with the correct answer. That's not dementia, okay? Mild cognitive impairment really only becomes dementia if a person's ability to be able to carry out their activities of daily living are impaired. So things like that would normally be given for dementia, in these cases, medications like rivastigmine, donanazepam, things that you folks, I'm sure, use day in and day out with your clients with dementia, can often help. We're going to go on now to talk about responsive behaviors. For example, the first one we're going to talk about is hallucinations. So hallucinations usually occur in later stages of Parkinson's. They don't occur usually in day one. If they do occur very early in the process, it's definitely often a side effect of their medication and needs to be addressed. The hallucinations can be, so hallucinations basically are things that people see, hear, feel, touch, and taste that are not based in reality. So they see or hear things that you and I cannot see or hear. The Parkinson's hallucinations are usually visual. They often start out in low light settings, for example, as the sun goes down, or in lower light settings in the evening, and start out as illusions. Something like a lamp could look like a cat, etc. They often also occur during sleep-wake transitions. So as they're going from a very deep sleep and sort of slowly waking up, they don't really know for sure exactly where they are. Things like that type of hallucination, they may not need treatment. Parkinson's hallucinations requiring treatment, however, can become more vivid and definitely more threatening. So again, it really depends on how it is affecting their quality of life. I have known many more elderly patients with Parkinson's who actually find seeing the little things, having a little dog with them that isn't really there, or having little people visit them, or seeing children play out in their front yard. Those things are not, they're what I call benign hallucinations, and often can be quite comforting, especially if people are living alone. Those do not need to be treated. Again, only when they become more threatening and more vivid and are upsetting to the person with Parkinson's. So it's important to find out how much are they really being bothered by them. So again, the side effects of the Parkinson's medications can make hallucinations worse. We now know that hallucinations are actually part and parcel of Parkinson's disease. They're there, and the medications act as a catalyst to bring them to the fore. One thing that I want to mention now, and I'm going to mention this a couple of times because it happens all the time. If the hallucinations are abrupt, in other words, if you've never heard out of the mouth of a person with Parkinson's that they see something that isn't there, and suddenly they're seeing things or hearing things that are not there, that has to be, you have to understand that that is always attached to some kind of an acute illness, an infection, dehydration, toxicity to something. It's really important to understand that. Nothing with Parkinson's happens quickly. So again, if there's any change in the motor symptoms or in the cognitive behaviors of people with Parkinson's, anything that changes quickly, please make sure that they're getting the proper lab tests, because sure as heck, they're going to have a urinary tract infection, a respiratory infection, they're dehydrated, something else is causing these to take place. So, for example, it may be necessary also to taper things like some of the more sedating medications that are given in adjunct with Parkinson's medications. Anything that would cloud their level of consciousness. Even antidepressants can sometimes cause this to be a problem. Again, as I said, just be aware that these things do not happen quickly for people with Parkinson's. Delusions often coexist with hallucinations, okay? They also are usually a side effect of Parkinson's medications. And just in case somebody doesn't understand a delusion, basically a delusion is a fixed belief that other people, that again is not based in reality. So sometimes people feel that their spouses and significant others are having an affair. They feel that someone is stealing from them. They feel that people are taking things that don't belong with them, etc. Again, when somebody has a delusion that's right out of the blue, you've never heard something like this from them before, please look again, ensure that there's not an infection, an underlying infection going on, and the same medications as you would give to people with hallucinations would be given for delusions as well. Okay. On we go. Now we're going to deal with the issues of depression and anxiety. So the prevalence of depression is very high in people with Parkinson's. Some literature says anywhere from 20 to 50%. Other research that's being done shows over 50% of people with Parkinson's do experience depression at some point in their journey. The reality is, I heard a doctor speak, and he said, I consider all of my patients to have either a reactive or a chemical imbalance type of depression until they prove me otherwise, which I thought was kind of an interesting way to put it. The other interesting factor about depression is that it often precedes the motor symptoms, and that's usually in at least 30 to 40% of cases, which is very important to understand that often some of these non-motor symptoms, both the ones we've talked about and ones we're about to talk about, these actually do often precede the tremor, the rigidity, the slowness of movement, etc. It typically differs from depression in the general population because there are less feelings of sadness or guilt. On the other hand, there is very prominent anxiety and apathy that is also linked with depression for a person with Parkinson's. I've had many, many people with Parkinson's themselves, but in particular care partners who are just tearing their hair out because the individual with Parkinson's, they're just not motivated to do anything. They lose all interest in things that they used to love to do. They're just not interested in anymore. They just become couch potatoes and really withdraw. Not their fault. These are all things that, as I said, go hand in hand with both depression and also the area of the brain that's damaged with Parkinson's disease is also your seat of motivation. So that's why people with Parkinson's don't feel like doing anything at all. Also, if you think of the symptoms of Parkinson's disease, which, for example, things like the masked face, etc., etc., those symptoms often look exactly like those for people with depression. So it's very common for depression to be missed. Fortunately, the good news is that thanks to books like this non-motor guide and also the ability of people with Parkinson's to be treated by doctors that do specialize in Parkinson's, when they can get an appointment with them, these features of Parkinson's are often much better addressed and treated, and so that's some good news. As far as what can be done is concerned, as you can use more Parkinson's medications, of course, the same medications that one would use for general depression. Antidepressants are very helpful. Nortriptyline, actually, which has been around for 1 million years. Back in my days in psychiatry, I was very used to giving this medication. The other name for this is Elavil, to people who are profoundly depressed with great success. And that is often one of the first medications that is given for people with Parkinson's, but also some of the what we call selective serotonin reuptake inhibitors, such the SSRIs, such as the cipralopram, I never can say that, citalopram, sorry about that, paroxetine. These things are often also given with great success. The bottom line, too, is that it's so sad when it's missed, because depression is really treated, really treatable, I mean, and the treatment is very successful. Anxiety often goes hand in hand. They can be seen independently of each other, but often it's kind of like a hand and glove. I see on the screen now is a similarity between Parkinson's symptoms and depression chart that I made up many years ago when I first started here. And as John said, I'm sorry that this is a little bit of an aside, but I've been here for a very long time, and I came to Parkinson's after spending many, many years in the world of psychiatry, and I thought, wow, it was like deja vu. I've seen these symptoms before, which is what prompted me to assist with the putting together of this chart. As I said, so there are many, many similarities, and that's why Parkinson's depression is often missed. Anxiety can also be what we call a preclinical Parkinson's disease factor. In other words, patients with Parkinson's often experience anxiety well in advance of their Parkinson's symptoms, at least, of their motor symptoms. John, am I still on track here? Are we okay? All right, sorry, double checking here, just making sure. And so as far as that is concerned, symptoms can even include things like panic attacks, just general anxiety disorder, phobias about things. People with Parkinson's often find that they ruminate excessively, especially on upcoming events. They're worried that they're not going to be able to control their anxiety when they're out in public, and sometimes these symptoms are very disabling and keep them from going anywhere. As I said, anxiety is commonly a prominent component along with depression. So possible treatments, make sure that an optimal treatment regime is put in place. Often anxiety responds to the same types of medications that depression does, and things like the benzodiazepines are often used for anxiety. But again, you have to be aware that for some people with Parkinson's, the problem can also cause, the medications can also cause some confusion, so just be aware of that. Okay, on to REM sleep behavior disorder, I think. Are we good? Oh, you've got excessive daytime. Oh. Did I get you off track, John?
That is my own doing.
That's
Sorry,
your own. Oh, yay. Okay, goody. Something Sandy's not responsible for. Okay. Okay, on to sleep disorders. So basically, REM sleep behavior disorder, rapid eye movement sleep behavior disorder. This happens when, what happens when when you and I go to sleep, we go through basically 5 stages of sleep, one of which is what we call the REM sleep behavior disorder level. At that time, we are in a very active dream state. And when you and I, without Parkinson's, go to sleep, we're normally quite paralyzed at this time. The muscle groups that stay awake at this time for those of us without Parkinson's are our eyes and our diaphragms. Just as well, or I wouldn't be talking with you today, and you wouldn't be sitting there if we didn't have our diaphragms working during our sleep process. But every other muscle in our body basically becomes paralyzed. So we may have a bad dream, but that's what it remains, a bad dream, or we often call them nightmares or night terrors, but we don't act them out. People with Parkinson's, however, their muscle groups stay awake and alert all night. So when they have a bad dream, it is very common for them to stay, to act out that dream. They can fall out of bed and injure themselves. They can certainly injure the people in the beds with them. I've seen many slides during presentations where it would appear, though, that they're a person with Parkinson's, a very black and blue face. In actual fact, that is a care partner of a person with Parkinson's who has actually been assaulted during one of these REM sleep behavior disorder types of nightmares, where people with Parkinson's have acted out their dreams, have thought that their care partners were the ones who were battling with them, etc., and that was their way of fighting back. I've also spoken, this is a very serious thing. I'm bringing it to your attention simply because it's often unreported. Unreported because people with Parkinson's and their care partners are embarrassed to tell their doctors that this is going on, because it looks like an assault. It looks like harassment. It looks like abuse. It is not. And if it's not treated, I have spoken to several care partners over the years who have found themselves being choked during their sleep and have just basically been able to get the person with Parkinson's to release their grip just in time. Otherwise, they would have died. So it is a very serious problem as dreams become more violent. So again, these symptoms can often precede the motor symptoms of Parkinson's as well. And it's, as I said, it's very, very common, needs to be treated. The good news is it can be treated. Often misdiagnosed, but there is good treatment for them, for the sleep behaviors. One particular medication that I think can really help, melatonin can sometimes help, but there is another medication called clozapine that is very, very helpful for people with rapid eye movement sleep behavior disorder, and it can often just cut the behaviors out altogether, which is of great reassurance, especially to the people, to the care partners of these individuals. Okay, so the next slide I have on my list, thank you, involves continence and diet. Okay, changes in taste and smell. Again, these are changes in smell is a very highly prevalent symptom for people with Parkinson's. I've heard some doctors, they have ongoing discussions about this. The latest research that I read said at least 90% of people with Parkinson's, and some of the doctors believe that it's actually 100% of people with Parkinson's that develop some sense of olfactory loss of sense of smell. So again, the olfactory bulb in the brain is obviously brought into question here, and because it's degenerating as well, and they think now some of the researchers believe that this could be indeed where Parkinson's actually starts. So there's much discussion, as I said earlier in the opening slide, about what is Parkinson's disease. We know what it's not. It's not just about the tremor, etc. It's about all of these other things. but the jury is still out in terms of where it actually starts. But loss of smell and certainly taste goes along with that. Where this comes into play, I believe, in terms of you dealing with people with Parkinson's is, you know, if you can't taste or smell your food, naturally you don't want to eat, and this can be a major problem. We'll talk about weight loss in a minute, but this can lead to that as well. Choking and swallowing difficulties certainly is a major problem, again, for many people. At least 50% of people with Parkinson's, and mild swallowing issues can be experienced early in the disease, and severe swallowing issues usually only occur in advanced stages. The problems with choking and swallowing, obviously these issues, without going into all of the physiological reasons, lead to aspiration pneumonia, and aspiration pneumonia is indeed the single biggest killer of people with Parkinson's disease. So again, if somebody, when you're feeding them or when a person with Parkinson's is eating, it often starts with something like a mild cough. But if it escalates, it warns you that there is a swallowing issue. A swallowing assessment is often in order in these cases, because they may have to have different consistencies of their food. They may have to have their liquids thickened so that they don't get to the back of the throat quite as quickly. And so again, it's really a matter of management, but more than that, it's a matter of awareness. Also, the changes in taste, smell, problems with choking and swallowing. Who would want to eat if they couldn't smell or taste their food and they were always choking on everything that they ate? So again, weight loss is much more prevalent in Parkinson's than weight gain. So these unexplained changes can take place, for many reasons. But again, weight loss is usually also independent of what people take in. Most people with Parkinson's say, but I haven't changed my diet. In fact, I'm eating more high-caloric foods. And so again, what can be done? And so these things, as I said, in the later stages, the oral nutritional supplements such as Ensure and Boost, as long as you're not giving them at the same time as their anti-Parkinson's medications, may be helpful. Things like, anything that they could swallow quite easily, like milkshakes and puddings and things that will help to boost their weight a little bit, can also be quite helpful. Okay, I think we have a couple of things. I'm not sure. How are we doing for time?
We're running close, but I think
Okay.
we do just have the 2 slides
Yeah,
to
we
follow,
do.
right?
Okay, so basically we're going to talk about continence now, and we're going to talk about the issues around constipation, which I believe is the first one. Okay, so I'm going to say this very loud and very clear. Constipation is not just bothersome for people with Parkinson's. It is a very severe problem, a very serious problem. People with Parkinson's must be monitored on a regular basis for their bowel movements. The reason being that that's where the colon, the small intestine, is where anti-Parkinson medications are absorbed. If a person with Parkinson's is constipated, the medication, the levodopa, never gets out of the small intestine. As a result, and into the bloodstream and back up to the brain. As a result, if a person with Parkinson's is constipated, the medications are rendered ineffective, and as a result of that, their motor symptoms in particular, as well as many of the non-motor symptoms too, will become severely impacted. So again, please be aware, people with Parkinson's have to have increased hydration, all of the things that one would normally do with someone who is constipated. increase in fiber, all of those things. Keep them moving. Physical exercise, even though they may not feel like it, is very, very, very important. And as I said, if somebody's constipated, their medications are not going to ever get back to the brain. Consequently, all kinds of awful things can happen, including they will develop what I call the mouse in the colon, that horrible thing that I'm sure as nurses have all seen at one time or another in our nursing career, the bowel obstruction, the second biggest killer of people with Parkinson's disease. First is the problem with the aspiration pneumonia. The second one is bowel obstruction. It kills. So again, constipation cannot be, in my opinion, addressed sufficiently or too much. That's just the bottom line. Okay, last and but not least is bladder dysfunction. Again, at least 50 to 60% of people with Parkinson's do experience some form of bladder dysfunction. A lot of people with Parkinson's themselves think that they're incontinent. In actual fact, they're not incontinent, they're just slow in getting to the bathroom. So some of the urine starts to leak out before they actually can get to the toilet in a timely fashion. So again, bladder symptoms are, there's a diverse range of them. Including nocturia is one of the most frequent ones where people have to get up to go to the washroom. Frequency, retention, urinary retention, of course, big red flag for people in general, but certainly for people with Parkinson's. If they're retaining some of the urine and they're not evacuating their bladders properly after going to the washroom, the rest of the urine just sits around in the bottom of the bladder, sloshes around. It's got a lovely moist, warm environment, and of course, bingo, there comes your urinary tract infection. So again, as I said, incomplete bladder emptying can be a major problem. Nocturia, sometimes desmopressin nasal spray can be used overnight. It decreases urine production. And also, that particular spray can be used, by the way, to treat orthostatic hypotension quite effectively. So we want people to drink lots and lots of water so they don't become dehydrated and their bowels move, etc. But guess what? Drinking too much water can cause decrease in sodium in the blood and cause electrolyte imbalances. So it's kind of you're damned if you do and you're damned if you don't. But as long as you're aware that these issues can be a major problem and very embarrassing for people with Parkinson's. Okay, well, that's the last slide I have. And so the good news is that I think I'm finished. But I guess if we have any time or there are any questions, I'd be happy to answer those now. I sure hope that this has helped to paint a bit of a picture about the fact that Parkinson's is not just a motor disease.
So I thank you for that, Sandy. And indeed, as you say, we're kind of close to time. We said 2 to 3 o'clock, and here we are at 2:59. So I will very briefly go ahead and conclude, and then ask anyone that if they do have any questions, feel free to ask them if you've joined us on the phone line or also in the chat box. But again, thank you all for coming. Thank you to Heather and RNAO for putting this together for us and for being a part of the session. And thank you, Sandy. I know that we work together every day, but I learn something every time I do hear a speak like this from you. And in particular, the last 2 slides, very salient, talking about their impact on overall Parkinson's symptoms, whether it's constipation or perhaps bladder dysfunction and some issues around urinary tract infections, things of that nature. We'll be speaking about that in our next and final session with RNAO on March 25th. So a lot of detail coming on issues around continence generally, so I look forward to that. I mentioned urinary tract infections, and I appreciated having it mentioned around hallucinations and some other issues that looking for another root cause of a number of these non-motor symptoms anyhow can be very relevant. Appreciated your mentioning some protocols around medication, also some ones to avoid on particular areas of treatment, and I hope that the folks attending found that valuable. So I'm not sure if, Heather, if you're still with us?
Oh, I'm still here. I just think this was great. I can't echo enough how much this has broadened my understanding of the non-motor symptoms. I really thought Parkinson's was about motor things, and Sandy, you've just outlined really clearly the impacts it can have on all these other parts of the body that we don't often think of it as Parkinson's, as part of the Parkinson's. So thanks.
You're welcome.
All right, well, thank you, Heather. Again, thanks to Sandy and RNAO and all of you for joining us. If you do have questions, feel free to ask them in the chat box. Otherwise, I hope to see everyone on March 25th, and thanks again for coming.
Bye-bye.
Bye-bye.